could this be tamponade? And what are the things we need to look at in echo to assess whether an effusion is actually clinical tamponade? So, when we look at pericardial effusions, it's actually dark around the heart. It's going to be an echolucent zone in the pericardial space. And even free flowing effusions that are small, they're going to accumulate first in the posterior pericardial space. When we are measuring these, the way that we assess them is if it's less than 5 millimeters at end diastole, it's minimal. If it is, 5 to 10 millimeters at end diastole, we consider it a small effusion. Moderate is 1 to 2 centimeters, and large effusions are more than two. I'm sorry, that's supposed to be that is centimeters, and large is supposed to be more than 2 centimeters um, uh, is going to be a large effusion. So one thing to be aware of, and this can come up in examinations, is how do you tell the difference between whether something is a pericardial effusion or a pleural effusion? And I can tell you this can get tough, right? Because a lot of times patients are retaining fluid in both spaces. And so what's really important to take a look at is your descending aorta. That is going to be the demarcation of where the pericardium starts and then where the pleural space is. So the pericardium is going to be anterior to the descending thoracic aorta. So always when you're taking a look at your posterior long axis view, make sure you keep an eye out for the descending aorta and anything interior to that. So this is your descending aorta, which means this is the pericardium. So this is going to be your pericardial effusion, and posterior to this is your pleural fluid. Now, which one is hemodynamically significant? Sometimes we see effusions and we say, oh, it's just this little, it's a small effusion. That's probably not going to cause any trouble. Oh my goodness, there's this massive effusion. This patient has tamponade. That's not always true. And so getting further information ends up helping us a lot in knowing whether this has the potential of being hemodynamically significant. So how quickly the pericardium fills has a lot to do with whether patients go into clinical tamponade. So basically, tamponade is the interrelationship or the relationship between the intrapericardial pressure and the intracardiac pressure. So you can have somebody who, if there's a sudden increase in the intracardiac pressure, even if it's not a lot of volume, they're because their pericardium is not compliant, they are going to go into critical tamponade a lot quicker than someone in whom the effusion takes a lot of time to accumulate, like a lot of times our end-stage renal patients, where they can have a very large effusion for long periods of time and it ends up not being hemodynamically significant. And it has to do with how quickly the pericardium has to kind of adjust to these increased pressures. Now, when we inspire, normally the pericardium is compliant enough to be able to not really change flow. But in tamponade, because the pericardium becomes a fixed space, when the patient inspires and right-sided pressures end up increasing, or right-sided filling ends up increasing, then left-sided filling decreases. And similarly, when the patient expires, then that right-sided filling decreases, and it gives the opportunity for the left-sided filling to catch up and fill. So this is what we see on echo as well. Now, if you put a pulse wave, again, we just want to look at sample volumes, at the tip of the tricuspid valve and look for flow as patients inspire and expire. So you want to take a look at quite a few beats. With tamponade, you are going to see that there is going to be at least a 60% variation in flow. And along the mitral valve, it's a 40% variation in flow, as you can see here. So as the patient is inspiring and expiring, you will see what we expect in terms of pulsus paradoxus here. Same thing if you put a pulse wave at the pulmonic valve or the aortic valve. This is again a reflection of why these patients are so sick, right? There is a compromise of their output as they inspire and expire because the pericardium is unable to be compliant to these increased pressures. So this is a patient, actually, someone in that we had in cardiology, and you see that there is this is the pericardial space, this echolucent space over here. The pericardium is this echogenic membrane over here, and just so we can anchor ourselves, this is your descending thoracic aorta, which means anterior to this is your pericardial effusion. So this is your pericardial effusion over here, which makes this your pleural effusion. So again, we see this very commonly, and it's very important to take a look, anchor yourself with that descending aorta. Anterior to that is going to be the pericardium. So any fluid in this space is going to be a pericardial effusion. And what we worry about and what you want to take a look at is there diastolic collapse of the chambers. And the first chambers that are going to be vulnerable to this are your right-sided chambers. So your lowest pressure chamber is your right atrium, which is going to be the most vulnerable to being compressed and causing clinical tamponade. This is your short axis view. And again, I want you to focus over here, right? We have the pericardium, and you see an early diastole, and I can sort of slow this down or pause this, but you can see there is collapse here. And this is in diastole. So this is concerning for tamponade. And we put a pulse wave here at the pulmonic valve, and you can clearly see that there's quite a bit of variation here in the VTI of flow going through the pulmonic valve. And this is your subcostal view, and I seem to be, understating with the other disease processes how important subcostal view is. It's essential when we're looking at tamponade, because not only does it give us a really good sense of what's going on anteriorly over here, and specifically looking at our most vulnerable structure, which is your right atrium, but because we go subxiphoid with percutaneous approach for pericardiocentesis, it's important for us to measure along here because your needle is going to come in here. So if you have more than 1 centimeter, this may be approachable by pericardiocentesis. Otherwise, you may not be able to get to it safely. And just to focus here, this is your right atrium and your right ventricle. And we see that this invagination of the right atrium is due to clinical tamponade. The right atrium is not able to open because of the pericardial effusion that is pressing up against it. And you see that there is RV collapse as well here. So again, subcostal view ends up being very important when we're talking about effusions, pericardial effusions. You want to measure along the RV free wall at end diastole, particularly at this space. If it's more than 1 centimeter, it's likely we can get to it percutaneously. If it's less than 1 centimeter, unlikely we'll be able to safely access this percutaneously, and the patient may need to go for a window. So in terms of, if you see a pericardial effusion, it's important to note that the size of the effusion itself does not reflect clinical tamponade. It's defined by intrapericardial pressure being higher than intracardiac pressure, which is why we give patients fluids, right? It's like you want to increase your intracardiac pressure if you can. There can be patients who they're very dehydrated, and even a small effusion can cause tamponade, whereas again, these end-stage renal patients with very high intracardiac filling pressures, they have a large effusion and they never go into clinical tamponade. And in these cases, again, it's important to look for other signs like chamber collapse and echocardiographic assessment, Doppler assessment for pulsus paradoxus.